going to present a case of 60 years old male presented with complaints of right and left knee joint pain. The past history of right and left knee replacement 5 years back, and right knee was infected and underwent a two-stage revision. The history of hypertension is present, so no other comorbidities. This X-ray of left knee joint presented with complaints of pain and swelling, history of trauma. It's diagnosed as a periprosthetic fracture, and MCL and LCL are intact, diagnosed by ultrasound. Clinically and hematologically, no signs of infection. So what do you say? Like X-ray, you can see the aseptic loosening of the femoral and tibial component also.
All right, so Rajesh, how do you want to tackle this?
So I think the two things, clinically or on the radiologically, it does look that this is an septic loosening all over. Whether it is septic or aseptic, maybe we should take it as septic and then do the tests and aspirate and prove that. Why the fracture has occurred? I think because the tibia is loose. I'm just a little surprised that there has been a fracture on the fibula in the past, because you can see it is well united. And I think this current fracture is something like a loose tibia and a stress on the lower part of the tibia. If it is infected, it will have to be done in two stages, where the implants come out and you'll need to stabilize that fracture with either a intramedullary cement stem, or I'm just thinking what else can be done. But you need to stabilize that fracture, take the implant out, get the infection out, and then do the surgery at a second stage.
All right, so let's assume it's not infected, because you didn't aspirate it, but you did blood tests.
No, aspiration is negative. So
okay, fine. So it's not infected. So Ashok, how are you going to tackle this? How are you going to remove these implants without displacing this fracture even more?
I don't think that should be a problem, Amar. This is loose. I suspect, in spite of what he's saying, there's possibly a septic loosening. But even assuming that this is aseptic, I think that should not be too difficult. There is a radiolucent line going all across the front and the back of the. So you put in a stacked osteotome, oscillating saw, whatever, and this should be pretty easy to remove. Keep the poly, remove the poly, do the femur first, and then get the tibia out. And I would do technically what you described, I mean, in one of the earlier sessions as a 1.5 revision. I mean, I would do that, send everything else for sonification, get the cultures. In the event that this happens to be infective, you've dealt with that part of the deal. Hopefully, that should stabilize it. If not, you can proceed accordingly.
So despite telling you there was no infection, you still have a high suspicion?
I would suspect
okay,
it,
and
yes.
that's fair enough. Harish, you want to add? Is anybody going to preliminarily fix the fracture first?
Yeah, that's what I'm telling you.
Okay.
If this patient was asymptomatic to begin with, and he has never complained of pain or discomfort on that side, clinically there is no infection, then I'll just treat the fracture first, fix it. It's not a very difficult fracture to fix. Give 3 months, 6 months for the fractures to heal. 6 months, 8 months down the line, when the bone has healed very well, I have a relatively simpler solution for revision. I can just remove the proximal plate, screws, and do a simple revision. If I want to do everything today, then I am getting unnecessary into complication. And okay. I don't think that is required.
I got your point. So Arun, do you agree with that plan, or how would you tackle this?
I think that this patient actually has severe osteolysis from poly wear. There's a huge defect on the tibia, huge defect on the femur. I'll discuss with him, be absolutely sure that it's aseptic, loosening, and probably try and do it in one go with a long stem on the tibia, along with a possible derotation plate if it's not stable enough. That's how I would do this, all components. And I don't know what's happening to the patella. I'm not sure if it's been resurfaced or not, but I might go ahead and even resurface the patella.
Can I say something? If you try to remove this implant, even if it is loose, try to get everything out, probably you're going to make a very shattered proximal metaphyseal area. You may not end up having a proper surface on which you can put an implant. You may end up requiring something like a tumor processes.
That's why I asked the question, who's going to fix the fracture first? Dr.
You
Mohanty,
can
what
put
do
a
you?
tentative plate there, just a temporary
Okay, so that's,
plate, and then go ahead and do everything.
Yeah, that's what I was telling, that,
okay.
you can temporarily unicortical plate, with putting unicortical screws there temporarily, then rim the tibia, and then you can go ahead with it. That should not be a
The other
problem.
thing
Dr.
that
Barry,
I,
do you want to add anything? Thorsten, you want to add anything?
You've said the main options, which is the best one could be debated.
So which one do you think? That's what we're here for. We're here to debate.
What are the facts? The facts are we have a state of a two-stage exchange. We have a loosening. I think that's an obvious loosening of the tibial component, femoral as well. So we have a loose implant, we have a fracture, we have probably an infection. First of all, you have to rule out the infection, of course. And then I would do exactly what Aaron said. I would change it into a stamped tibial component, and probably I would do some kind of additional stabilization with a strut graft. My question, Arun, is why would you replace the patella? The patella is very thin, it's very sclerotic, and if you put in a patella resurfacing there, the danger of fracturing the patella is quite high.
agree with that.
So, yeah, I mean, I would, in my opinion, put a plate on first, unicortical, just to stay low. Because if it does displace, when you're removing components, even loose components, it's difficult. You got to hyperflex, you got to do stuff to that leg, and yeah, you can make this much more complicated. So let's see what you did.
No, clinically infection is ruled out. Even intraoperative, although we sent for frozen section, infection is not present.
Wait, go back to the x-rays. Hold on. Yeah, the x-ray. One back. So, yeah, no, yes, so what happened? You put it in and you went out the back? All right, so tell us what happened. So did you fix the fracture primarily?
Is that a right knee or a left knee?
No, showing right knee also. Left, we are discussing about left knee.
Okay, so this is the right knee.
Yeah,
So his right knee is loose, different problem.
these are the intraoperative left knee fractures. The implants are loosened, and infection is ruled out by frozen section. And Arun Mullaji was asking about the patella. Patella has found that fractured patella. It was fixed with wires. And
So
one stage revision was done.
It had been resurfaced, the patella?
No, it was fixed. Patella was fractured.
Did you fracture it?
No.
It wasn't fractured on the
It
x-ray
was
that you
fractured.
showed.
Earlier it was fractured.
Show me the fracture.
Radiologically, you cannot see. It's a thinned out and fractured. Yeah.
Okay, so now, now I see the radiologic wires, so I see it was fixed. All right, so how did you tackle the fracture in the tibia? You didn't plate it or do anything preliminarily to stabilize that fracture on the tibia?
Sorry?
You didn't do anything to the tibial fracture to stabilize it before you tried to put the stem down?
No.
Okay.
These are 18 months old post-op x-rays. Shows fracture healed well.
All right, any comments from the panel?
I think it looks very good.
It's good. I mean, I think the whole question there revolved around whether it was going to turn out to be infected.
Right.
And I was suspicious it was going to be. Apparently it wasn't, but I was suspicious about it, just like Thorsten was. And if you'd gotten in there and it looked infected, I think that would have really changed the whole plan.
Yeah. I can't hear.
The patella fixation, the patella was fractured,
Do you
you have
have a
done
merchant
wiring.
view? Do you have a merchant view? Skyline view?
So the wires, you show the slide, you have wire inside, right, in the patella side, the femoral component side. So what they're doing there?
You're worried about the wires hitting the trochlea,
Yes,
correct?
yes.
So no option left to fix the fracture.
The wires are on the undersurface of the patella?
Yeah.
Could you have
you
used
cover it
a
with-
suture instead of the wire? an ethibond, for instance, because when you have periprosthetic fractures of the patella, typically you don't want to be putting internal fixations in terms of metal.
Or fiber wires.
So
Fiber wires have been.
Was it a vertical fracture,
But
a
to
horizontal
number
fracture?
It's a vertical fracture.
Vertical fracture.
It's a
So,
vertical fracture, and the reason they're worried about it is because the intraoperative photograph, you could see the wires on the undersurface of the patella. So that's why they're worried, I
yeah,
think.
no, I understand that. But my point is, if you're going to fix it that way, I would have just left it. That might have been a better solution than having a wire touching the trochanter. That's going to cause a major problem. You know, so if it was a vertical fracture patella, you could probably get away with leaving it or using, as you said, sutures. Now, if, you know, you go to Arthrex and some of the other sports companies, they have really robust sutures and fiber tapes and fiber wires that can, you know, hold bones together.
But the wire's not there in the X-ray on the left, the lateral view. So did you go and take it out later?
Yeah, we have taken out.
All right.
Can I ask a question, please? What did you do exactly to the fracture in this side here, in the audience? Hello. What did you do to the fracture of the tibia when you stabilized the tibia? How do you do that, you know, intraoperatively? What do you do? Did you put a temporary plate as was discussed? Or
No, I didn't put any plate.
how did you manage to put and manipulate the entire knee without
Intramedullary
displacing?
reamer. I stabilized with intramedullary reamer.
Intramedullary?
Reamer.
Probably somebody was holding the tibia from outside and trim the tibia, stabilize the tibia from outside.
But the stem length which he
Yeah,
has
the
used
external
for
fixator.
the stem length which he has used for the, you know, for the tibia, he hardly has gone beyond the actual lower end of the fracture. How can that stabilize the fracture? I mean, it's good that it has healed. The patient is lucky. But I would be scared to just leave it like that with that short a stem, which has hardly gone not even an inch beyond that lower end of the fracture. And to expect it will heal without having a collapse.
He's beyond it, I think, far enough. I don't have a problem with the length of the tibial stem.
It's small. It's not engaging the cortex there.
As per Dr. Ranawat, that success cannot be challenged.
Exactly.
Good that it has healed. Patient is lucky.
All right, anything else to add?
Sir,
It's
sir,
a
what was
right
the-
side,
What was the range of motion, post-op range of the motion, this patient?
What's his post-op range of motion?
I'll show you later.
Okay, so let's go.
It's a right side. Already 3 years back underwent 2-stage revision.
You only get one case. Let's go.
These are the intraoperative pictures. These are the post-op X-rays, 18 months.
All right, so you use bone graft on the femoral side. Yeah, I mean, I think, you know, now we're seeing the use of cones and sleeves for more of these defects rather than using, you use allograft?
No, cement and screws.
Just cement and screws, like, okay.
Are you really happy with it? I mean, you changed the joint line dramatically. You have a patella brachia. Probably this is a PS design or
PS design.
PS design. Probably severe instability as well. So I mean, why didn't you change the joint line better? You build up the tibial part. What's about the screws? Do you have? Can you explain me the screws? Why didn't you build up the femoral component? Let the tibia in the same level, then you have a good joint line and.
No, these are the primary implants, PFC design. So only we have option of maximum 17.5 poly. So if you go down the tibia, the poly will, you need more, means constrained poly.
No, he's saying, why did you not distalize the femur so that your joint line is restored rather than raising the joint line by taking the femur so proximal?
No, it was more bone loss. I thought means already I have distalized more femur.
Yeah, I mean, listen, I understand that you're doing what you're doing with what you have, right? You probably don't have sleeves, you don't have cones, you don't have a hinge. Like that medial femoral condyle is at risk for breaking and fracturing, and this knee is at a high risk for a hinge. If I were doing this knee and I felt there was good stability after I did it, I would make sure it was an easy conversion to a hinge, because you now have a problem if that medial epicondyle breaks.
Yeah, but I mean, every system, this system has augments.
Yes.
And you could use augments in the femoral part.
No, 100%. No, yes. So,
And you can bring it down. And you don't have to build it up on the tibial part. I mean,
I 100% agree.
As you said, it's correct. The patient is very poor, so budget is low. I cannot use sleeve stems
so I can,
managed with screws and cement.
then it's clear, okay.
Okay, excellent. Is that it? You done?
Post.
All right, great. Next
Thank you,
presentation.
Dr. Jagadish. Next, we have Dr. Karthik Reddy.
Here, the post-op range of movements. No, last one.
All right, just tell us what it was. If it was good, that's great. Okay, good job. All right, next.
Thank you.